Hi everybody, and welcome to our module on hypersensitivity. Hypersensitivity is an immune response that causes disease. Generally, it's an exaggerated or inappropriate immune response, and sometimes people will interchangeably use the word hypersensitivity with allergy. Technically, allergies are a subtype of hypersensitivity. We'll talk about these first. They're the so-called type 1 hypersensitivity reactions. All hypersensitivity disorders follow a similar pattern. The first contact with an antigen sensitizes a patient to that antigen. This generates an immune response. It may involve antibodies. It may also involve memory cells. It's different depending on the disease you're talking about. And then the second contact with the antigen results in a hypersensitivity reaction, and patients develop symptoms from an overreaction of the immune response. And this general pattern plays out in all hypersensitivity diseases, but then the specific immune system reactions are broken down into four distinct patterns, and they're called the type 1, type 2, type 3, and type 4 hypersensitivity disorders. We'll start by talking about the type 1 hypersensitivity reactions, and type 1 reactions are what most people call allergies. These are immediate immune system reactions to antigens that occur within minutes, and some of the common triggers of type 1 reactions are things like pollen and pet dander and peanuts, and you may know people who have allergies to these things, or you may have some yourself. The reason these occur is because there are preformed IgE antibodies inside the body from primary exposure, and these antibodies are bound to mast cells, and then the antigen binds and cross-links the IgE antibodies, and as a result the mast cell degranulates. This is a picture of what's going on down here. These are IgE antibodies. An appropriate allergen can cross-link several of them, and this causes the mast cell to degranulate and release its contents into the tissues, and that's what causes the symptoms. The immunology of type 1 reactions all has to do with IgE antibodies. Susceptible individuals make IgE antibodies to antigens where other people do not. The majority of people instead make IgG antibodies, and these do not trigger a hypersensitivity reaction. The IgE that is synthesized in susceptible individuals comes from B-cell class switching. This is driven by a Th2 T helper response, which is part of the humoral response. I talk about this in more detail in the T-cell module. A key cytokine is IL-4. IL-4 triggers the B cells to class switch and produce IgE, and it's very important in type 1 hypersensitivity reactions. And then finally, you should recognize that complement is not involved here. IgE does not activate complement, and the complement system is not an important component of the type 1 reactions. So what are the symptoms of a type 1 hypersensitivity reaction? Well, it depends on the organ system you're talking about. In the skin, type 1 reactions manifest as urticaria or hives. This is a picture of hives right here on the screen. In the respiratory tract, people get runny noses, which is rhinitis, or they can develop wheezing, and we'll talk about how asthma is a type 1 hypersensitivity reaction. In the eyes, patients can develop conjunctivitis. Their eyes will become itchy and red and watery. And in the GI tract, people can develop diarrhea. Anaphylaxis is an example of a systemic type 1 hypersensitivity reaction. Patients who get anaphylaxis develop itching and diffuse hives and erythema. They will develop respiratory distress from bronchoconstriction. They can develop hoarseness because their larynx will swell and become edematous. They can also get GI symptoms like vomiting, cramps, and diarrhea. And this can lead to shock and death, and the treatment of choice for anaphylaxis is epinephrine. It will vasoconstrict to raise the blood pressure, it will dilate the bronchioles, and it will help relieve many of the symptoms. Patients who have a history of anaphylaxis often carry what's called an EpiPen around with them, so that they can administer epinephrine to themselves if they develop one of these reactions. You may have heard of the term atopy, or you may have heard that a patient is atopic, and this refers to a genetic predisposition to hypersensitivity. These patients often have multiple different types of type 1 reactions, so they may get urticaria sometimes, rhinitis other times, and also asthma, and usually there is a positive family history of a similar reaction. So what are some examples of type 1 hypersensitivity reactions? Well, asthma is a classic one. In asthma, patients' mast cells degranulate in response to allergens, and they develop wheezing and shortness of breath. Some penicillin drug allergies are type 1 reactions, especially patients who get urticaria or hives after receiving penicillin. Some seasonal allergies are caused by type 1 hypersensitivity reactions. These are often referred to as allergic rhinitis. Allergic conjunctivitis is a type 1 reaction. So is a peanut allergy, which many children have, and also a shellfish allergy, which many people have as a food allergy. There can be two waves of symptoms in type 1 hypersensitivity reactions, so-called early symptoms and late symptoms. The early symptoms occur within minutes, as the name implies. They are caused by degranulation of cells, leading to release of preformed mediators, especially histamine. They are also due to the synthesis and release of leukotrienes and prostaglandins. And the early symptoms include things like edema and redness and itching.
About 6 hours later, late symptoms can develop. These are due to the synthesis and release of cytokines, which takes time. This leads to an influx of inflammatory cells like neutrophils and eosinophils, and one of the symptoms that can sometimes be a late symptom is induration of the skin. So now let's talk about some of those mediators of type 1 reactions. One of the most important is histamine. Histamine leads to vasodilation, which causes the warmth of the skin seen in type 1 hypersensitivity reactions. It also leads to increased permeability of venules, and this causes swelling. And in addition, it can cause smooth muscle contraction, and this can lead to bronchospasm. Other important mediators are those derived from arachidonic acid. These include leukotrienes, prostaglandins, and thromboxanes. They can be produced quickly as part of the early phase, and they can also be produced later as part of the late phase of type 1 hypersensitivity reactions. Leukotrienes and prostaglandins and thromboxanes are part of a class of signaling molecules called eicosanoids. Eicosanoids are derived from lipids in the cell membrane of cells. There's an enzyme called phospholipase A2 that can pull lipids from the cell membranes and create arachidonic acid. And from arachidonic acid, the enzyme lipoxygenase can synthesize leukotrienes, and the enzyme cyclooxygenase can synthesize prostaglandins and thromboxanes, and all of these molecules can play a role in type 1 hypersensitivity reactions. There are many eicosanoids that play a role in type 1 hypersensitivity reactions and in the inflammatory response in general. But I've listed on this table on the slide some of the prostaglandins and leukotrienes that I think are most relevant to type 1 hypersensitivity. I've also shown a review article at the bottom of the screen if you want to read more about this topic. One of the most important mediators for type 1 hypersensitivity in terms of eicosanoids is prostaglandin E2. This prostaglandin is responsible for many of the signs and symptoms that we associate with hypersensitivity and inflammation. For example, it can cause redness through causing vasodilation. It can lead to edema through increasing vascular permeability. It can raise the set point for temperature in the hypothalamus, and that's what causes fever. And it can also sensitize nerves, and that's what causes pain. Prostaglandin D2 is an important eicosanoid that leads to bronchoconstriction. It also draws eosinophils into sites of type 1 hypersensitivity reactions. Leukotriene C4 and D4 cause vasoconstriction and bronchoconstriction. And then finally, leukotriene B4 has been shown to draw in neutrophils and eosinophils to sites of inflammation in type 1 hypersensitivity reactions.
I've listed some other type 1 mediators on the screen here. ECFA stands for eosinophil chemotactic factor of anaphylaxis. It's preformed in mast cells, and it attracts eosinophils, which are often involved in allergic reactions. They have various roles. Some of them are pro-inflammatory and some of them are anti-inflammatory. I've shown a nice review article down here on the bottom of the screen if you want to read more about the role of eosinophils in allergy. Serotonin can also be released by mast cells. It causes vasodilation. Platelet activating factor is a substance that causes bronchoconstriction. And then finally, there are proteases called neutral proteases like chymase and tryptase that are released by mast cells, and these can dissolve proteins. And heparin is also released by mast cells, which, as you know, is an anticoagulant. Allergy testing for the presence of IgE antibodies to an allergen is sometimes done to see if a person is sensitized to a particular substance. This is done by administering a small amount of the allergen, either by pinprick or puncture of the skin or by an intradermal injection, and a positive response is formation of a wheal, which is a raised indurated red area of skin where the antigen was injected. Also, patients are sometimes desensitized to allergens if their response is dangerous or life-threatening, or sometimes this is done when people are allergic to drugs that they really need for a particular condition. What you do is you gradually administer increasing amounts of the allergen, and slowly the response changes from an IgE response to an IgG response. These IgG antibodies have been shown to block mediator released by mast cells. This is called a modified Th2 response. And this is sometimes done in my field of cardiology when people are allergic to aspirin, but they really need to take the drug for a cardiac condition. Moving ahead, let's talk about the type 2 hypersensitivity reactions, and these are autoimmune disorders where antibodies attack our own cells or tissues. In type 2 hypersensitivity reactions, antibodies like IgG and IgM are directed against our own tissue antigens. They bind to and cause damage of normal structures in the body. There are three mechanisms by which these antibodies cause tissue and cell damage. This can be through phagocytosis, through complement-mediated lysis, or through antibody-dependent cytotoxicity. And this is a picture to help you remember that in these disorders you have a tissue or a cell, and you have either IgG or IgM antibodies binding to the tissue or cell to cause disease. In some of these disorders, antibodies bind to cells, and those cells are consumed by phagocytosis.
Phagocytes like macrophages will recognize either the Fc receptors on the IgG antibodies or C3b from the complement pathway. Damage can also occur to cells and tissues through complement. IgM or IgG can trigger the classical complement cascade. They can form the MAC, and this can lead to cell death. And then finally, in these disorders, there is often antibody-dependent cell-mediated cytotoxicity. This is where natural killer cells bind to the Fc portion of IgG and then release their contents and destroy cells and tissues. Rheumatic fever is the classic example of a type 2 hypersensitivity disorder. In rheumatic fever, antibodies to strep pyogenes cross-react with cardiac myocytes. This can lead to myocardial damage and damage to the heart valves. Another classic example is exposure to the wrong blood type. If you are exposed to the wrong blood type, you may have lysis of the transfused cells by circulating IgG, and this is what causes erythroblastosis fetalis when Rh-negative mothers have Rh-positive babies. Another example is autoimmune hemolytic anemia. In this case, antibodies bind to and destroy red blood cells. Methyldopa and penicillin are two drugs that classically can cause an autoimmune hemolytic anemia. The drugs bind to the surface of red blood cells, and then antibodies can bind to these targets and destroy the red blood cells. Another example is mycoplasma pneumonia. Patients with mycoplasma pneumonia sometimes develop autoimmune hemolytic anemia, and that's because for reasons that are poorly understood, this infection induces antibodies against red blood cells. Another example is pemphigus vulgaris, which is a skin disease where antibodies are directed against desmosomes in the epidermis. Also, Goodpasture syndrome. This is a condition where patients develop the nephritic syndrome and pulmonary hemorrhage, and it's caused by antibodies against type 4 collagen. And finally, myasthenia gravis is an example of a type 2 hypersensitivity reaction. In this case, there are antibodies against acetylcholine receptors. And all these disorders share the common theme of antibodies directed against tissues or cells in our own bodies. Type 3 hypersensitivity disorders occur when antigen and antibody complexes form, usually with IgG. These complexes then activate complement, and this leads to tissue and cell damage. What's different between type 2 and type 3 is that in type 2, the antibodies directly attack tissues or cells. In type 3, they bind to small antigens, and then they deposit in the tissues as a complex of an antigen and antibody together, and that leads to disease. There are two subtypes of type 3 reactions, generally two ways in which the reactions occur. The first subtype is called a serum sickness, and the second subtype is called an Arthus reaction. We'll talk about both of these now. Let's talk about the serum sickness form of a type 3 hypersensitivity reaction first. In this form of disease, there are immune complexes, which are those antibody-antigen complexes circulating in the bloodstream, and they deposit in lots of places, causing systemic disease. The antibodies are usually IgG or IgM, and these are good complement activators. And you can just imagine those complexes circulating all through the body and depositing in skin and kidneys and joint and triggering systemic disease. Once they deposit, they trigger an immune response from complement activation, and in addition, they activate macrophages and neutrophils via their Fc receptors, which serve to bind to these cells. The term serum sickness is historical, and it's helpful to know the history lesson because it can remind you of the symptoms and pathophysiology of these disorders. So a long time ago, doctors would take horse plasma or horse serum from horses that had been exposed to diphtheria and scarlet fever, and they would administer the serum to human beings in an attempt to passively immunize them against those infections. What they saw is about 5 to 10 days later, the people who received the horse serum would develop a classic triad of fever, rash, and arthralgias. What was happening is the patients were mounting an immune response against horse serum antigens, and immune complexes of horse antigens and antibodies were depositing in the skin and joints to cause this classic triad of symptoms. So patients who have a classic serum sickness type 3 reaction can get urticaria and palpable purpura from complex deposition in their skin. They often have low serum complement levels because these immune complexes consume the complement proteins. They will have an elevated sedimentation rate from inflammation. They can develop diffuse lymphadenopathy. They also can develop acute glomerulonephritis from deposition of immune complexes in the kidneys. A classic serum sickness is very rare in the modern era. There are only a couple instances where you may see something like this. People who are administered rabies or tetanus antitoxins sometimes experience a serum sickness. These antitoxins are pooled plasma from humans and sometimes horses, and it's designed to passively immunize people against rabies or tetanus, and sometimes a serum sickness-like illness can develop. Rarely, penicillin can cause a serum sickness-like reaction. The drug can act as a hapten, which is a small molecule that elicits an immune response, and antibodies can be formed and bind to penicillin and then deposit in the tissues and cause serum sickness. And then finally, certain monoclonal antibody therapies like rituximab, which is an antibody against B cells, and infliximab, which is a TNF-alpha antibody, have been reported to cause serum sickness-like illnesses, presumably by binding to antigens and depositing in tissues. What you will see are other type 3 disorders which are mediated by immune complexes but don't necessarily cause a classic serum sickness-like picture. So post-streptococcal glomerulonephritis is a disorder mediated by immune complexes. There are antibodies bound to strep antigens and they can deposit in the glomeruli. Lupus is an immune complex mediated disorder. There are antibodies to DNA and they deposit in tissues and cause disease. And then finally, polyarteritis nodosa, when it's associated with Hep B, can have an immune complex mediated mechanism where complexes bind to Hep B antigens and deposit in the tissues to cause the symptoms of this vasculitis. The Arthus reaction is the other type of type 3 hypersensitivity reaction. It is also caused by antigen-antibody complexes. However, the complexes don't circulate in the plasma and deposit in tissues. Instead, they form within the tissues where they cause disease. This is a local reaction, not systemic like serum sickness. It's usually in the skin. What happens is you inject some antigen and then preformed antibodies in the plasma or tissue will bind the antigen and form immune complexes locally right in the skin where you directed the antigen. The Arthus reaction is named for Dr. Arthus, and what he did is he would inject antigen into the skin of animals. So he would inject the first time and there would be no reaction. He'd inject the second time, there would be no reaction. He'd inject the third time, there would be no reaction. And then around the fourth or the fifth injection, he would see swelling and induration at the site of injection about 4 hours after he put the antigen under the skin. So why had there been no reaction during the first 3 injections but reaction after the fourth? Well, the answer is that the first 3 injections had triggered an immune response and antibodies had formed. Thus, when he did the 4th injection, those circulating antibodies bound to the antigen and caused a reaction where there had been none the first 3 times. So local immune complexes form, and that's what causes the Arthus reaction. It's usually about 4 to 10 hours after injection. It's much faster than the 5 to 10 days for serum sickness because the antibodies are already present. And contrast this with type 1 skin reactions, which occur within minutes. Those are caused by mast cells and IgE antibodies. For these reactions, it takes a few hours for the immune complexes to bind. Once they bind, they lead to complement activation and edema and necrosis. And you can identify Arthus reactions with immunofluorescence staining. You will see antibodies and complement in the vessel wall to know that they are being deposited in the tissue and causing the reaction. So what are some clinical examples of the Arthus reaction subtype of type 3 hypersensitivity reactions? Well, it has been reported with certain skin injections very similar to Dr. Arthus's initial description. If you administer a tetanus booster to a patient or a diphtheria booster or a Hep B booster, you are administering antigens into the skin of somebody who has been previously exposed. They may have circulating antibodies that can deposit and bind to the antigen at the site of skin injection, and this will cause swelling and redness at the site a few hours after injection. This has also been reported with people who have diabetes and have to repeatedly administer insulin under the skin. Another example of an Arthus reaction is hypersensitivity pneumonitis. This is not in the skin. This condition is called farmer's lung, but this is a hypersensitivity reaction to environmental antigens. Some patients with farmer's lung have circulating antibodies, and when they inhale certain antigens, those bind in the tissue of the lung and cause an Arthus-type reaction. The final type of hypersensitivity reaction is the type 4, which is also called delayed type hypersensitivity. And in contrast to all the other types, this is entirely cell-mediated and does not involve any antibodies at all, which makes it very different from types 1, 2, and 3. This is a memory T-cell response to an antigen. The classic example of a type 4 hypersensitivity reaction is the PPD test for tuberculosis. In this test, you administer a small amount of a protein called tuberculin under the skin. Patients who have been previously exposed to tuberculosis will have memory T cells that can recognize the tuberculin antigen. That antigen will be presented by antigen-presenting cells and placed in the context of MHC class II, where memory CD4 T cells can recognize it and respond. There will be a Th1 response, which is a cell-mediated response. Interferon gamma will be secreted, which can activate macrophages, and IL-12 will be secreted from macrophages, which can in turn stimulate Th1 cells. The result is that there will be redness and induration 24 to 72 hours later in people who have been previously exposed to tuberculosis. If the person has not been previously exposed, they will not have memory T cells, and this delayed type reaction will not develop.
One thing you should recognize is that the immune system response to many pathogens is similar to a type 4 hypersensitivity reaction. When the immune system responds to mycobacteria like tuberculosis or fungi like the fungal pneumonias, it is a cell-mediated response that shares many similarities with a type 4 hypersensitivity reaction. A couple of diseases that are good examples of type 4 hypersensitivity are contact dermatitis, which includes poison ivy. This happens when chemicals like plant oils attach to your skin cells, and then CD8 T cells recognize those oils and attack the skin cells. This leads to erythema and itching. And as you know, if you've ever had poison ivy, it doesn't occur while you're still in the woods. It occurs the next day or the night after you get home. It takes about 12 to 48 hours for this delayed type hypersensitivity reaction to occur. And contrast this with a type 1 hypersensitivity reaction, which occurs within minutes. Poison ivy is very different from that. It is cell-mediated, and it takes several hours to days to occur. Another disorder that's believed to involve type 4 hypersensitivity is multiple sclerosis. The pathogenesis of this disease is poorly understood, but it's believed that type 4 hypersensitivity reactions to myelin basic protein are one of the mechanisms that lead to demyelination and cause the neurologic symptoms. And that concludes our module on hypersensitivity.